ileocecal valve. Distal ileum open to the medial and posterior aspect of the large bowel at the junction of the cecum and ascending colon. Two horizontal folds of circular muscle of the ileum and the mucosa project into the lumen of the colonic side, and the folds extend laterally to form the frenulae. The valve function is to relate passage of content from ileum to cecum and prevent reflux from large to small bowel. There is variant anatomy. Lateral ileocecal valve seen in about 7.5% and posterior in about 5%. Radiological features of ileocecal valve. Gaseous distension of colon proximal to the site of obstruction. There is two types of large bowel obstruction, type A competent ileocecal valve and type 2 incompetent ileocecal valve. In type A competent ileocecal valve, there is excessive dilatation of the cecum with or without large bowel extension, without small bowel dilatation, with or without small bowel dilatation. يعني أقصد excessive dilatation يصير بالcecum and large bowel. In type B, when incompetent ileocecal valve, there is dilatation of the large and the small bowel without excessive distension of the cecum. Barium enema examination. The valve appear as a polypoidal or bilabial filling defect, depend on the state of contraction of the valve. In contracted valve, the barium fill the narrow slit between the folds. Here, barium enema examination show polypoidal filling defect of the ileocecal valve. And here, the barium fill the slit between the two folds of the contracted ileocecal valve. CT scan, fast accumulation around the valve make it easily identified. This is very marked in the elderly women. This is an axial CT of the abdomen shows the ileocecal valve normal. Now we will talk about appendix. Appendix arises from the cecum at the posteromedial wall at the convergence of tinea, about 2.5 cm below the ileocecal valve. It has on mesenteric mesoappendix, which is a triangular fold extended from the lower border of the ileum. So the appendix is mobile. It's a tubular thin walled structure which contains lymphoid tissue, about 12 to 24 cm in length and width equal or less than 6 mm. Its lumen is wide in infant, then obliterated after mid-adult life. So acute appendicitis is rare in the extremes of life. Variations of the appendicular site. The most common site is retrocecal, 64%, followed by pelvic, 32%, then subcecal, 2%, then pre-ileal, 1%, then post-ileal, 0.5%. Blood supply. Blood supply is by appendicular artery, which is a branch from the ileocolic artery, which is a branch from superior mesenteric artery through the mesoappendix, and this is the sole blood supply. Unlike in gallbladder, there is multiple collateral blood supply from the hepatic bed. So the rate of perforation in following acute appendicitis is much more than that of perforation of gallbladder following acute cholecystitis. Venous drainage is via the corresponding vein into the superior mesenteric vein. Lymphatic drainage is along the ileocolic artery to the superior mesenteric artery group to the para-aortic lymph node. Autonomic nerve supply arises from superior mesenteric plexus and efferent sensory fibers carried on the sympathetic nerve fibers to enter the spinal cord at level of T10, correspond to the umbilical dermatome. This picture shows the ileocolic artery, which is the branch from superior mesenteric artery, give ileal branch, which gives superior mesenteric appendicular artery alongside the mesoappendix. And this picture shows the lymphatic drainage of the appendix to the ileocolic lymph node group to the superior mesenteric lymph node group of para-aortic lymph node. Radiological features of appendix. Plain abdominal film. Fecalith or a fluid level of appendix may be visible in the right iliac fossa in approximately 10% of individuals. This plain abdominal X-ray shows fecalith in the right iliac fossa. Barium enema. If the lumen of appendix is intact, it may fall on barium enema examination. The lumen is often obliterated in the past mid-adult. To fill the appendix, the patient should be supine because its orifice on the posterior aspect of the cecum. Some elevation of the head is also helpful. Ultrasound of appendix. Appendix appear as a blind and non-peristaltic tube. Its position is variable. When it's subcecal, being less likely to be obscured by cecal gases, but when it is retrocecal, visualization is aided by compression of the cecum. Probe used in compression to reduce obscuring gas in overlying bowel and to push the bowel loop away. Typically, high-frequency linear array probe 7 to 12 MHz is used to scan and evaluate the appendix. Patient examined in supine position, then turn him to 45 degree, then left posterior oblique position, then rescan again in supine position. Here an ultrasound of normal appendix. This is the cecum and this is the iliac vein. Normal diameter of the appendix. And this ultrasound picture shows the normal 5 layers of the wall of the appendix. This includes the outermost layer is the echogenic cirrhosis, followed by the hypoechoic muscularis propria, followed by echogenic muscularis mucosae, followed by echogenic submucosae, followed by hypoechoic muscularis mucosae, followed by innermost echogenic mucosae. CT scan. The normal appendix is usually identified arising from the cecum inferior to the insertion of terminal ileum. It can be followed on sequential images and may have long and somewhat tortuous course. This is coronal CT image of the abdomen, show the appendix filled with gas. Appendix have variable location. Have variable location. Retrocecal area is the most common, and in a pregnancy, the enlarging uterus push the end of the appendix lateral to the right lobe of the liver. Here an axial CT of the abdomen show retrocecal appendix, and here an coronal CT of the abdomen show inflamed appendix inferior to the right lobe of the liver. Acute appendicitis is an acute inflammation of the vermiform appendix. It is a very common condition in general radiology practice and is one of the main reasons for abdominal surgery in young patients. Acute appendicitis is typically disease of children and young adults with a peak incidence in the second to third decade of life. Pathology. Appendiculitis is typically caused by obstruction of appendiceal lumen with a resultant build-up of fluid, suppuration, inflammation, secondary infection, venous congestion, and finally ischemia and necrosis. It causes the most common cause lymphoid hyperplasia about 60%, followed by appendiculitis in about 33%, followed by foreign body 4%. Then Crohn's disease or other causes, example stricture, trauma, and parasite, rare causes. Radiological features. Plain abdominal film is infrequently give the diagnosis, but identify the following: free air, fecal in about 7 to 15%, inflammatory mass if developed, show medial displacement of the cecal gas and the mural thickening. Small bowel obstruction with air fluid level and dilatation is seen in about 40% of perforating appendix. Ultrasound. Features on ultrasound include blind end, peristaltic, non-compressible, dilated loop, more than 6 mm outer to outer layer at the level of maximum tenderness, prominent and echogenic surrounding fat, echogenic appendiculitis with posterior acoustic shadowing, prominent surrounding lymph node, mural thickening more than 3 mm, periappendiceal inflammatory mass or abscess, distinct wall layer, and this feature absent in necrotic appendicitis, mural hyperemia on Doppler study. This ultrasound picture shows inflamed appendix, which is dilated and surrounded by echogenic fat. And here, appendix also inflamed, dilated, surrounding by echogenic fat, and show wall hyperemia on Doppler study. Here are some of acute appendicitis complication. Appendiceal perforation show cut in the edge of the appendix with periappendiceal fluid collection. And here, tip appendicitis show the normal diameter of appendix, only dilated tip of the appendix, which is surrounded by echogenic fat. Appendiceal phlegon, an inflammatory mass occur beside the inflamed appendix, which is surrounded by echogenic fat and inflamed ileum. And here, another complication of appendicitis include appendiceal abscess. show the echogenic fat and also the collection with the echogenic foci with dirty shadow, this main gas. CT scan. CT is highly sensitive, 94 to 98, and the specific 97 in diagnosis of acute appendicitis. Radiological features: dilated appendix more than 6 mm, thickened wall more than 3 mm, and wall enhancement on contrast, periappendiceal inflammation, fat stranding or fluid collection, thickening of cecal apex, arrowhead sign. This is an axial CT of the abdomen, show appendicular and this pericecal fat inflammation. And this show the cecal arrowhead sign, which means the cecal thickening pointing to the orifice of the appendix. Now we will talk about the large intestine. Its variable in length is average of 1.5 cm. As far as the rectum, the colon is marked by 3 flattened bands of longitudinal incomplete muscle called tinea coli. The tinea is about 30 cm shorter than the colon. This causes the circulation of the colon, which appear radiologically as incomplete septa called haustra. Along the free surface of the colon, except for the cecum and rectum, there is fat-filled peritoneal tags called appendices epiploicae. There are especially numerous in sigmoid colon. This picture shows gross anatomy of large bowel, appendix, cecum, ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon, and then rectum. This picture shows the longitudinal tinea coli from this haustra, incomplete septa, and this appendix is epiploicae. Peritoneal relation of the colon. We divide it into parts which are retroperitoneal and parts with mesentery. Parts which are retroperitoneal, ascending colon and descending colon. Parts with mesentery, transverse colon, cecum, appendix, and sigmoid colon. The splenic flexure is attached to the diaphragm by phrenicocolic ligament. The greater curve of the stomach lie on the concavity of the transverse colon by gastrocolic ligament, which continue as the greater omentum. Here, gastrocolic ligament continue as the greater omentum. Upper 1/3 of rectum covered by peritoneum, anteriorly and laterally. Middle third covered anteriorly, and lower third is completely below the pelvic peritoneum. Arterial supply. Superior mesenteric artery supply parts derived from the midgut, the cecum to mid-transverse colon through. Ileocolic artery supplies cecum appendix, beginning of ascending colon. Right colic artery point. Inferior mesenteric artery supply the ascending colon to the. Hello?
نسمعش دعاء.
Inferior mesenteric artery supply the descending colon to the rectum through. Left colic artery supply descending colon. Sigmoidal artery supply sigmoid colon, and superior rectal artery supply upper rectum and upper anus. Each of these vessels of an inferior mesenteric artery anastomose with its neighbor, forming the marginal artery of Drummond. This diagram shows superior mesenteric angiogram. Number 1, superior mesenteric artery. Number 2, give ileal branches. 3, apogeuginal branches. 3, ileal branches. For continuation of the superior mesenteric artery. Number 5 is the common trunk of ileocolic artery and right colic artery. This is ileocolic and this is the right colic artery. Number 8 is the middle colic artery. The region of colon between the supply of superior and inferior mesenteric artery, which mean area of splenic flexure, called the watershed area. This area is more vulnerable to reduce the blood supply during a hypotensive episode, leading to ischemic damage. Venous drainage, veins corresponding with arteries drain into the superior and inferior mesenteric veins. Lymphatic drainage. Cecum will ascending colon and the transverse colon to the peripancreatic nodes and superior mesenteric group of para-aortic lymph nodes. Left colon, sigmoid colon, superior rectum into the inferior mesenteric group of para-aortic lymph nodes. This diagram shows the ileocolic or the right colic with middle colic vein to the superior mesenteric vein, and this descending will sigmoid and upper rectum to the inferior mesenteric vein. To the splenic vein, which combine with the superior mesenteric vein to form the portal vein. And this shows the lymphatic drainage of the right-sided colon and cecum and appendix to the superior mesenteric lymph node, and the descending colon and sigmoid and upper rectum to the inferior mesenteric lymph node group. Radiological features: the plain film, gas within the colon, outlining the colon or part of it. The circulation of the colon by Taenia coli give rise to septa called haustra. Haustra are fixed anatomical structures in the proximal colon, but in the distal colon require active contraction for their formation. This may absent distal to transverse mid-colon. Upper limit of normal diameter of a transverse colon on a plain film is up to 5.5 cm, and for the cecum is 9 cm. Beyond these limits, in right clinical setting, there is risk of cecal perforation. The numerous gas fluid level may be normal. Cecal air fluid level seen about 18% of normal film. Here, a broad spectrum of normal plain abdominal X-ray. This diagram will be differentiate between features of a small and large bowel obstruction on plain film. Position of the loop in small bowel central, in the large bowel peripheral. Septa here complete valvulae conventi and here incomplete haustra. Number of loops several in small bowel. Diameter less than 5 cm in small bowel. More than 5 cm in large bowel. Solid feces absent and here may be present. This show plain abdominal radiograph shows small bowel obstruction. Note the the dilated loop in the center of the abdomen with complete septa, valvular conventi, and here the large bowel dilatation in the periphery of the abdomen with incomplete septa called haustra. Double barium enema examination. The entire colon and appendix cecum and ascending colon. Oblique position with caudally angled view required to visualize the sigmoid colon. Ileocecal area is visualized when the patient left side raised because of the posteromedial position of the junction. The haustra may be well seen on double contrast barium enema like here. Gaseous distension may obliterate these distally to the mid-transverse colon. CT of the abdomen. The cecum and ascending colon seen anterior to the posterior abdominal wall on right side. The right paracolic gutter is lateral to the ascending colon. Right infracolic space lie medially. Hepatic flexure is lateral to the second part of the duodenum and below the right lobe of the liver. The splenic flexure is behind the greater curvature of the stomach and the anterior splenic tip. Descending colon anterior to the posterior abdominal wall on the left side. Transverse colon vary in position because of its variable length and mobility because it has mesentery. Here, axial CT of the abdomen show normal large bowel, look large bowel at the periphery and small bowel at the center of the abdomen. CT colonograph is the technique in which the colon is distended with air or gas after administration of an antispasmodic agent. The colon followed from the rectum to cecum sequentially. CT image to screen the mucosa for polyp or any abnormality. Here, CT colonograph show a mucosal lesion. Chilaiditi syndrome is a rare condition in which the colon is interposed anteriorly to the liver, reaching the undersurface of the right hemidiaphragm, and it's one of the causes of the pseudopneumoperitoneum. Here, transverse colon below the right hemidiaphragm causes elevation of it. Thank you.
شكرا جزيلا دكتورة دعاء، عاشت ايدك. بس نختار حسنى.
بلى أستاذ. بلى أستاذ. الإكزام angiogram Number 1A superior mesenteric artery.
superior mesenteric. بتول B
نعم أستاذ. B right colic artery.
right colic. اسماء معين C
Ileocecal artery. Ileocecal.
إليوكوليك بالضبط. داليا باسم
Left common iliac artery.
left كمان إليك. وظل أخير واحد الإي هبة مهدي
نعم أستاذ. middle colic artery.
middle colic. أوكي. أستاذ محمد تفضل.
نعم يا عمو.
هذه خلاص. نعم أستاذ. The sigmoid colon is retroperitoneal. False.
False.
Retroperitoneal.
زينب سعيد.
نعم أستاذ. Number 2, the marginal artery of Drummond is a single arterial trunk formed by anastomosis of arteries around the inner border of the colon. True.
سالي كاظم.
The chain of coli are thickening of a longitudinal muscle layer. True.
حوراء حسين.
نعم دكتور. Number 4, the colon has circulation due to mucosal fold. False, because it's due to tinea cola. Tinea are shorter than the colon, which gives its appearance.
جيد. علي شبر. Number 5.
نعم أستاذ. The appendices epiploic are sparse in the sigmoid colon. It is false high.
جيد. عندك بعد شيء خلاص.
يا عمو